အားလုံးပဲမင်္ဂလာပါဒီနေ့ NUG ရဲ့ Final Birthday Weekend ဒီချိန်ကိုတက်လာတဲ့မောင်နှမလေးအကုန်လုံးကြိုဆိုပါတယ်ဒီနေ့သင်တဲ့ topic ကတော့ Management of Breast Cancer ဆိုတဲ့ topic ဖြစ်ပါတယ်သင်ကြားပေးမယ့်ဆရာကတော့ UK က Surgeon Consultant ဆရာဖြစ်ပါတယ်ရှင့်ဟုတ်ကဲ့ဆရာစလို့ရပါပြီ
မင်္ဂလာပါကျွန်တော်ဒီနေ့ပြောမယ့်အကြောင်းကတော့ breast cancer အကြောင်းပါပဲကျွန်တော်ဒီနေ့မှာ breast cancer ကို I'm going to discuss following with the headings. So breast cancer is the second most common cancer following the lung cancer in women. At least 1 in 8 women in their lifetime will be diagnosed with breast cancer. Every year, 2 million new cases as being diagnosed with the breast cancer, and it is also a leading cause of death in women from the breast cancer, its consequences. In US alone, every year, 250,000 new diagnoses and the mortality rate of 40,000 every year. In UK, the new cases are 55,000 annually, and the mortality is also a little bit over 100,000. But the survival rates are also very good, a 76% survival rate over 10 years. But the Asian, Africa, South America, the third world countries, the developing countries are also catching up with the numbers recently, at least for the last 10 years. This is also blamed to that lifestyle changes, hormonal reproductive changes, and environmental factors. Last 10 years or so, the disease-free survival and overall survival of breast cancer are improving because of the earlier diagnosis in earlier stage and advances in the treatment overall. Obviously, the disease is female dominant, and male breast cancer is only about 1%. There are two peak age incidence is between 55 to 65 and over 75. But generally speaking, the breast cancer can happen from age 25 to age 90. The family history, the effects of female hormone over the breast, when you can look at the hormonal replacement therapy, oral contraceptive pills, pregnancy, no pregnancy, age as fast pregnancy, breastfeeding, it's all are the risk factor for the breast cancer for women. But above all, the lifestyle changes, environmental factors are recently found out to be a higher risk and increase in third world country, developing countries. How do we diagnose a breast cancer patient? There are two groups of patients we diagnose for the breast cancer. One is symptomatic patient, and another one is asymptomatic patient who comes to breast screening program. So in the symptomatic patient, we can categorize in 3 groups. One is a breast-related symptom. Second one is symptoms related to nipple area complex. And third one is symptoms related to metastasis. So breast lump is the presented to the breast clinic, one-stop breast clinic, about 70 to 80%. Although mostly are benign, the malignant breast lump presentation is about 5 to 10% in all breast clinics. There are also presentation of the asymmetry, thickening, deformity of the breast. And even recently, we see a lot of locally advanced breast cancer in breast clinic, because in COVID era, like ulcer, very large cancer, and fixed. The breast cancer can present it to the breast clinic with inflammation, inflammatory breast cancer, edema, and sometimes associated with the abscess. The breast pain is the represent only very small amount, about 1%. The symptoms related to nipple areolar complex is nipple retraction, nipple discharge, blasting nipple discharge, edematous changes, which most of the time we see as a pathogenesis of the nipple. Sometimes we see patient in breast clinic with axillary limb adenopathy, and the symptom of metastasis from the bone metastasis, fracture, pathological fracture, jaundice. So once a patient is coming to breast clinic, what we call a one-stop breast clinic for symptomatic. So what we do is triple assessment. Triple assessment is clinical examination, imaging, and biopsy at the same day, and to make the diagnosis. And we can discharge from a clinic and reassured. Breast screening and surveillance. So these patients, asymptomatic patients, are invited to breast screening program, especially in UK, is called National Breast Screening Program. The women from age 47 to 72 are invited for 3-yearly mammogram. Because when you look back the risk factor, the two peak age group of 50 to 55 and 65, they are all included in the risk group. So the reason is mortality benefit is outweigh the false positive and unnecessary biopsy risk, which means all the women are screened with the mammogram. And then if there is any suspicious lesion found on the mammogram, they've been invited back, called back for further assessment and biopsy. The surveillance is only for the high-risk patient outside the age of the breast screening program. So younger patient or higher patient, older patients. So these patients being the program, they are in the program and then regularly screened annually. Before we're going to continue for the diagnosis, I would like to tell about some anatomical consideration. The breast tissue, the breast is comprised of glandular tissue and a stromal tissue. In glandular tissue, we've got ducts and lobules. So here you can see that the basic unit of the breast tissue is called terminal duct lobular unit. It comprises of lobules and ductules, which converge towards the main lactiferous ducts, which opens into the nipple. So whatever happened in the breast is always come from terminal duct lobular units. So this is a little bit of explanation about the normal to invasive breast cancer. So it is a cross section around here. like every cells in our body, our breast tissue derived from the breast stem cells, which can involve into the epithelial cells and myoepithelial cells. So that's the epithelial cells. The red one is the myoepithelial cells. So they both derive from breast stem cells. The epithelial cells, they respond to hormone and produce milk when required. They will respond, they are usually ERPR positive. So myoepithelial cells, they just for the movement of the milk, transport of the milk, they don't respond to hormone and they are ERPR negative. They, like any other cells in our body, they involve in a cell cycle, and they involve in the hyperplasia that could happen at some point. These hyperplasia become an atypical hyperplasia, and these atypical changes can lead to DCIS, which is a ductal carcinoma in situ, which I will come a little bit later. And these DCIS changes, if they breach the myoepithelium and basement membrane, that's what we call it invasive ductal carcinoma. Ductal carcinoma in situ, they contain within the basement membrane and myoepithelium, they don't spread. But invasive ductal carcinoma is already breached out of the barrier, so they can spread into the lymphatics and vascular spaces. So all the breast cancer are, we call carcinoma because of the epithelial origin. So it can divide into non-invasive and invasive type. So in the past, we used to call ductal carcinoma in situ and lobular carcinoma in situ. But now the lobular carcinoma in situ is called, it is no longer a malignant. It is called lobular neoplasia. It is a risk factor for the cancer. So in invasive cancer, there are mainly two types. One is called the non-special type, which is a ductal and lobular cancer, lobular cancer and ductal cancer. Ductal cancer is a majority, about 70 to 80%, and lobular cancer is about 10 to 15%. There are special types called papillary type, medullary type, metaplastic, and tubular type. There are also one type of cell we found in Paget disease of the nipple. Sarcoma, very rare. Angiosarcoma, phalloid tumor, it's fibroepithelial hyperplasia leads to anaplasia, and lymphoma, very rare breast cancer. So invasive breast cancer, and sometimes we call it infiltrated type. So there are main two types, that's the ductal type and the lobular type. So people may think that ductal type come from ductal epithelium, and lobular type come from lobular epithelium. But when the cancer come out, the epithelial cell derived from that changes to both. It can be changed to both ductal and lobular type. But the ductal type usually present with a mass lesion. The reason why is when the malignant cell induce a fibrous response when they infiltrated into the breast parenchyma. So that's causing the reaction and become a palpable mass, which you can feel it, and you can see in the radiological density, and ultrasound scan changes also. Lobular type is very difficult to recognize and detect, both clinically and radiologically. It could be multifocal in the same breast and multicentric in the same breast. they usually ER positive. Pagelocity nipple. Pagelocity nipple is clinically there's a lesion around the nipple with persistent scaling, edematous, ulcerated lesion, and sometimes a nipple involved with the nipple destruction. Usually that pagelocity nipple associated with the underlying breast cancer, which is mainly is a DCIS in about 80%. Sometimes we can even associate it with the mass or mammographic abnormality. Usually we diagnose with the punch biopsy or full thickness wedge biopsy of the nipple areolar complex. So once patients come in, we have a history, clinical examination, and we will do comments to imaging. What are we going to do? In imaging, we can do two types. One is a diagnostic imaging for the breast cancer, is a bilateral tubule mammogram, which is a cephalocaudal and the mediolateral views. Another one is called ultrasonogram. This is targeted imaging, and we use it for guided biopsy. Ultrasonogram is not a screening tool. So this is the mammogram machine. So you have to take it in patient in the upright position. So you can see that basically the breast is a 3D structure outside the body. So you have to put it onto the two plates. And you are doing the CC view, cephalocaudal view. What are we going to see on the X-ray? So we're going to see X-ray on microcalcification, mass lesion, specular lesion, and distortion. So these are, in this picture, you can see that you can compare it both sides. This is the left side, this is the right side. In the right side, you can see ill-defined mass. This is a CC view. This is the ML view. So how do you differentiate between CC and ML view? So ML view, you can see that this is the pectoral muscle. So when you look at the CC view, this is a nipple. This is a mass lesion. So it looks like behind the nipple. So see there, again, this is a nipple. So slightly pull in, you can see the nipple changes, nipple retraction. So sometimes we didn't see anything apart from anatomical distortion that usually we see in the lobular cancer. In ultrasound scan, we can see malignant, we can see benign lesions. So after the mammogram, so we found an abnormal lesion in the right breast. So we proceed to ultrasound scan, the same patients. So in ultrasound scan, they found two areas of changes. So one is the anechoic lesion, another one is the hypoechoic lesion. So you can see the malignant mass with the edges are irregular. This one was cyst, aspirated to emptiness. And this malignant was a biopsy for further investigation. So this is the methods of biopsy technique. So finding the aspiration with the ultrasound guided, what we do, we can use that, the syringe and needle. So you can use 16 gauge, 18 gauge needle. Which mass lesion we can do it? We can use a cyst for aspiration therapeutic also, liminal bulb aspiration, but nowadays we don't do any more FNA for lymph node. We prefer to have a true cut, either true cut or excision biopsy. Punch biopsy, this is a punch biopsy needle. I've shown this one there. So the tip is very sharp, and the length of the punch biopsy is about 7 to 10 millimeter, which can go through beyond the dermis and the subcutaneous fat. So punch or wedge biopsy, you have to take it perform with aseptic condition with the local anesthesia, and you have to close that area you biopsied. True cut biopsy, usually 14 or 16 gauge. This is the true cut biopsy needle. Most of the time we do it image guided, ultrasound guided, or sometime you can do a clinical core biopsy if it is big enough to palpate. Another method of cytology is called smear for the nipple discharges. If there is any suspicious of blood or blood-related color, black or brown, we have to send for smear cytology. So now the patient has come to one-stop breast clinic. We have to take the history, clinical examination. The patient had imaging, and then we have taken a biopsy. So this is just want to show how biopsy being reported initially. So not related to the other patient. So it's a left breast biopsy. So B5B malignant. There is no in situ component. The provisional grading was 2, ER negative, PR negative, HER2 negative. So based on this information, we have to treat the breast cancer patient. How do we treat patient? It is a multidisciplinary team approach, very important for any cancer patient, especially in a breast cancer. We have a team of radiologists, pathologists, which are very important for diagnosis, and surgical team and oncologists are for the treatment point of view, and these are supported. Breast cancer is very, very important for the journey of the patients. We have a large group of support team, and we often refer to psychologists and geneticists for further assessment. So now patient has a diagnosis of breast cancer. These are all options of the treatment for the breast cancer patient. Whenever we have a patient with the breast cancer, we always want to perform a surgery first in a view to cure. And then we can do a surgery in curative setting, palliative setting, as well as all these options I'll go through later. The surgical treatment is the mainstay of the treatment of the breast cancer. So in surgery, we can do 2 things. One is called breast conservation surgery, wide local excision. It is very important to do to have a breast tissue for a woman. So because with the wide local excision, we can retain shape, volume, and cosmesis as much as possible. But if you are going to have a breast conservation surgery, you will require a radiotherapy to the breast. The breast conservative breast surgery is a gold standard for the breast cancer surgery, but it can also bring drawbacks of the margins are not clear. She will require more operation. So it could be a longer step for the before we reach into the further treatment. Another type of surgery is called a mastectomy. It could be done without reconstruction. It could be done immediate or delayed reconstruction. Auxiliary node staging is also very important for the further treatment, management of the breast cancer. So we can do, if sentinel node biopsy, if the clinically and the ultrasonically node negative patients. If it is a node positive patient, we can perform a clearance. So what is breast conservation surgery? We call it wide local excision, and layman term we can also call lumpectomy. So we do it in T1 and T2, which is the 20-30 millimeter size. It depends on the size of the breast. How do we do that? Complete resection of the tumor with the surrounding normal tissue. So that is the example of the tumor. We aim to get a normal breast tissue of 5 to 10 millimeter from the skin down to the chest wall. We take it as a block. And usually we leave a clip in the tumor bed for the targeting of the radiotherapy. If the tumor is palpable, we just do a wide local excision. But in case of the non-palpable cancer, small lesion, you will require localization technique of wire or radioiodine C. So these are some photos of X-rays of the postoperative, immediate postoperative X-ray of after the wide local excision. You can, this is the radioiodine C excision. Right breast is being cranial, caudal, medial, lateral, orientated. And this one is wire-guided wide local excision. Again, orientated. This little marker is the radiologist put it in after biopsy. So again, this one, we have a good margin. You can, surrounding is right in the middle. And in this patient, we don't have no good margin and caudally. So after the X-ray, we take it out more tissue out from the that caudal area to clear it out. This is a sentinel lymph node biopsy with the patent blue technique. The patent blue has been injected around the nipple. We use a subdermal plexus of lymphatics, which travel to one of the gland, maybe two, maybe three. And then the tumor there on the top of the, so we take it out through the axillary incision. So the patient always have a two incision, one over the breast and one under the armpit. So second operation is called mastectomy. So mastectomy, we have a simple, only perform simple or total mastectomy. We no longer perform radical mastectomy, which is cause a lot of destruction on the chest wall. What are the indications for the mastectomy? So large cancer, small breast, or patient wish to have a mastectomy. A previous radiotherapy to the breast for any reason, Probably most common thing is they have a previous breast cancer, they have conservative breast surgery followed by radiotherapy, and they have a recurrence of the breast cancer. In that kind of situation, we have to do mastectomy. Then some patients have a mental field radiotherapy or some immuno suppression for bone marrow transplant, things like that. Inflammatory breast cancer, following the Neo-Juvent chemotherapy, we have to advise mastectomy without reconstruction. There are some soft indication of mastectomy, but just as a nipple. We could do a central-wide local excision, or sometime we do a mastectomy. Or if there's any contraindication of radiotherapy like scleroderma, underlying lungs or heart or pacemaker, these, when we discuss an MDT meeting, the oncologist has advised us to do a mastectomy as the patient is not indicated for fit for the radiotherapy. So the chemotherapy. The chemotherapy is a systemic therapy, so we can give it to them as a neo-adjuvant or as a adjuvant treatment. So what is neo-adjuvant therapy? The neo-adjuvant therapy is the chemotherapy given to the patient prior to surgery, surgical treatment. So why we give it to the chemotherapy first? Maybe the patient may have a large cancer. So we can downsize the cancer, which can be more manageable size, which can be achieved breast conservation surgery. So in some patients, we can achieve complete pathological response, especially in triple negative ER/PR, HER2 negative receptor negative patient. We can treat micrometastasis. We neo-adjuvant chemotherapy to increase the chance of survival, the risk of recurrence, the same as the adjuvant chemotherapy, which can be given postoperatively to prevent the relapses. So systemic chemotherapy also given prior to Herceptin treatment. I'll come to that later. Chemotherapy is usually given every 3 weeks for 6 cycles in adjuvant setting. We have various regime. It depends on patients and type of the cancers. There's a treatment called electrochemotherapy, which we can give it to the patient with cutaneous recurrence. They give bleomycin intravenously, and at the same time with a low dose of electric currents towards the cutaneous recurrence. So radiotherapy is to prevent local recurrence. It can prevent about up to 50% in 10 years. Usually follow the conservative breast surgery. It can be given whole breast or partial breast radiotherapy tangentially. Sometimes radiotherapy is given following the mastectomy if patients have a large tumor or multiple lymph nodes, heavy lymph nodes involvement. It can also bring some adverse effects on heart, lungs, underlying ribs. It can cause angiosarcoma. It can cause squamous cell carcinoma of the skin. Intraoperative radiotherapy, we do an operation and then patient receive a radiotherapy, one shot. Radiotherapy can be given as a palliative treatment for symptomatics, such as pain, back pain. There's an ulcer, we give it to them to improve the healings. The hormonal therapy. Hormonal therapy is given to the woman with the breast cancer, which estrogen receptor and progesterone receptors are found to be positive. We use it to reduce the effects of hormone on the body. It can be given orally, it can be achieved by surgically. So in the hormonal therapy also, we can use an adjuvant setting, Neo-Juvent setting, or primary/palliative settings. So in the adjuvant setting, we give it to following the surgery after 5 years. If the patient has to have a chemotherapy, the hormonal therapy is given after completion of the chemotherapy. In the Neo-Juvent setting, especially locally advanced cancer, especially in older age group, especially in a lobular type, and then we give it for about 4 to 6 months. It takes time to respond, and then we can reassess and whether they have become operable or not. So primary or palliative setting patient, we given to patients who are not medically fit for surgery. So this is how we check estrogen and progesterone receptor positivity. This is called Aldred scoring. So the number of stains, number of the cell stains, the intensity of the staining. The score is 0 to 5 and 0 to 3. So strongly positive, always better than the negative and low staining. There are 2 types of oral hormonal therapy. One is called 2 groups. One is selective estrogen receptor modulator called tamoxifen. It can be given to pre and postmenopausal, both pre and postmenopausal women. Usually 5 years, it can reduce the 50% contralateral breast cancer recurrence up to 10 years. But there also bring some side effects, complications. So we need to warn the women who are taking tamoxifen about the abnormal vaginal bleeding and deep vein thrombosis. Leg swelling, leg pains, very rarely it can cause deep vein thrombosis of the arm. Another one is called Aromatase Inhibitor. The mechanism of action is inhibits the enzyme aromatase, which convert androgen to estrogen. We can only use for the postmenopausal woman. Because of its action on the bone, so we need to initially monitor with the bone DEXA scan. If a patient has osteoporosis, they must have a treatment for osteoporosis. The main side effects of the disease, the drug, is muscle, bones, and joint pains. That's a commonly complaint from the patients. In younger patients or high-risk patients, we can use an ovarian function suppression, which can be achieved by Zoladex or surgically removing the ovaries. But they will have a severe menopausal symptom. So you need to think twice before we proceed for ovarian function suppression. So immunotherapy is called HER2 receptor positive patients. So that's the CRB2 in the memory cells, which is positive. They deem to have a immunotherapy called trastuzumab treatment. It can bring cardiac toxicity. So they must have a regular echocardiogram monitoring during the treatment. Chemotherapy must be given prior to the HER2 treatment. And usually the Herceptin treatment takes about 12 to 18 months. The latest treatment for the immunotherapy called anti-CD46 treatment called palbociclib in the advance of metastatic disease. These are the prognosis and predictive factors. So what is a prognostic factor? So before going to the prognosis, I'll go in for the staging of the breast cancer. So this is I take it from the AJCC, the American Joint Cancer staging. This is a TMN staging we widely used. So tumor, lymph nodes, and metastasis. So TIS is called carcinoma in situ, no invasive component. T1 up to size of the tumor, T2 50 millimeter, T3 over 50 millimeter, and T3, T4. They also sub stage of A and B. Lymph nodes, N0 node nodes, N1, 1 to 3 nodes, N2 over 3 nodes, and metastasis, so on. You can make the staging clinically or pathologically. But pathological staging is more accurate than the clinical staging. So the prognostic factor, what is the prognostic factor? So obviously you can see that if the tumor size is bigger, the grade is higher, the type, they bring that bad prognosis, especially lymph nodes, more than 4 or 5 nodes, ERP are positive, negative, HER2 positive, negative, and distant metastatic lymphovascular invasion. This all those you can calculate the prognosis of the patients. Predictive factors. In these days, we are more interested in predictive factor than the prognostic factors. So why? What is the predictive factor? So we can predict the outcome of the particular treatment. So, and then we can guess the prognosis. So especially in the tumor type, lobular type, they have a good response to estrogen receptor, hormone receptor treatment. They bring, we can guess that. Tubular type also, they usually ER positive. They have a very good prognosis. Medullary type, metaplastic type. They are usually a triple negative receptor status. So obviously they bring a bad prognosis factor. They can recur quickly. So ERPR status, positive, negative, we know that is going to get good response and good prognosis. Currently, we have Chi67, which show epithelial proliferation. If it is the higher number, which means it can recur early. But I'm not sure it is in the particular treatment outcome prediction. But oncotype DX is we can predict for a chemotherapy, which can be patient can get benefit. So I'm going to pick up a little bit back from the previous talk, which is patients come in to the one-stop breast clinic, or patient being referred from a breast screening program, finding of the malignant mass. So patient has a treatment surgically. Patient have a treatment with chemotherapy, Neo-Juvent or adjuvant treatment, radiotherapy, and hormonal blockade or Herceptin treatment. Now I'm going to go on to special circumstances breast cancer, especially pregnancy related breast cancer. So what is the pregnancy related breast cancer? The breast cancer happened during the pregnancy or within a year of delivery. That's what we call it, pregnancy related breast cancer. Often we got a late diagnosis. Because of the late diagnosis, they got delayed treatment. Especially with the pregnancy, we have to consider the welfare of the both mother and the unborn child. So in this case scenario, the multidiscriminating approaches is very important. We need to get obstetrician and neonatal team to get on board. These kind of pregnancy-related breast cancer are usually associated with triple receptor negative and often related to inflammatory type breast cancer. The treatment regime depends on where is the pregnancy is. Either first trimester, second trimester, or third trimester. If it is in the second trimester, we can give a chemotherapy. If it is in the third trimester, we wait everything. We have a early induction and proceed to surgery as soon as we can. If the patient being diagnosed after the delivery, it is a little bit more easier for us to manage.
Okay,
only a few slides left. Thank you. Another special condition, or young woman below the age of 35. Again, here we have a delayed diagnosis because of the clinically it's not suspicious. Usually the lump present always we find as a benign most of the time. We detect them in late stage. They usually associate aggressive triple negative breast cancer. They usually present with already metastasis, and they always bring high recurrence rate. Because of the younger age group, they may not have a complete family. So we need to discuss about the future family, future eggs harvesting and freezing. Psychologically traumatic, and we need to assess genetically whether they are family history of breast cancer. They often require aggressive treatment, and they need longer follow-up. Male breast cancer is a very small proportion, probably less than 1%, mostly ductal type, and we usually perform a surgery most of the time. In hormonal therapy, the tamoxifen is the treatment of choice. So locally advanced cancer, I have touched a little bit in the earlierly. So usually larger cancer, fixed skin or the muscle ulceration, often inoperable. So we can give a systemic therapy first to downstage, and then followed by the surgical treatment when possible. Metastatic disease management is mainly for the palliative and symptomatic control. So who we should genetic assessment? So all the patients under the age of 35, all the patients under the 55 with the triple receptor negative, all male patients, strong family history patients. So we, as soon as we've got a diagnosis, we refer them for geneticists or family history team for further assessment as soon as we can. Especially at the age of 35, we perform before the, we try to get the results before the surgery, so we can discuss about possible risk reducing surgery of the opposite side. How can we prevent breast cancer? It is very difficult to prevent a breast cancer because mainly that's the individual the individual the gene abnormality case. So surveillance, only we prevent is we can prevent getting a larger late stage. So the surveillance, which means in the high risk patient, we can detect, diagnose an earlier stage. There's a lot of study about the chemo prevention. In some cases, we will use tamoxifen, both tamoxifen and aromatase inhibitors, but only a license for 5 years. But the most important thing is reducing the risk factors, so which we can do these things all the time. Another one is called risk reducing surgery. So how long are we going to follow up these once the diagnosis of breast cancer? We usually follow up with annual mammogram for 5 years. And then we used to follow up every year in clinics. But with the COVID, in some cases, only we follow up the very high risk patients. And this is the most important thing. Breast awareness for every woman, and regular self-examination is recommended. So I have some case presentation at the, so about 3 cases before I concluded. So this is the one of the patients with, you can obviously see that there's a little mass lesion in the right side. This is the ML view. So because you see that pectoralis muscle. This is a nipple. So probably it's lower part of the right breast. Very small size, about 10-15 millimeter. Again, the same patient. CC view. This is the nipple. So here it says about 12 millimeter new lesion. So what is the, so that this is the combination. You can see that now. What are we going to do then? This surgically. So this is you can see that she's got larger breast, very small non-palpable lesion. So what we can do is we can do a conservative breast surgery, which is wide local excision and sentinel liminal biopsy. And because of it's non-palpable, we have to do some form of localization, either wire or a seed, radioiodine seed, guided wide local excision. So the biopsy reported back as 18 millimeter grade 2 ductal. The margins are clear. The lymph node was benign, both ER positive, HER2 was negative. So what is she going to have for the adjuvant treatment? There is no indication for chemotherapy, as because of the small cancer grade 2 ductal lymph node negative. So no indication for chemotherapy. HER2 was negative, so no indication for Herceptin treatment. So she will require radiotherapy because of that wide local excision, conservative breast surgery. She will require 5 years of a hormonal blockade in terms of aromatase inhibitor because of the ER positive and the annual file. That's the next case. You can see the right breast larger cancer than compared to previous patient. So this is a nipple. This is the nipple there. So upper central, upper outer quadrant. So 55 years old, clinically 45 millimeter. Skin edema, possible inflammatory type. Core biopsy shows triple negative, grade 3. Axillary lymph node also positive. What are we going to do with this patient? So possible inflammatory breast cancer, triple negative, grade 3. She's being referred to oncologist for Neo-Juvent chemotherapy. So once she complete that Neo-Juvent chemotherapy, she will be back for total mastectomy and level 2 clearance because of the previous lymph node positive case. This is the same patient with as other, the ultrasound scan. This is a third case scenario. This is 85 years old lady with a dementia, locally advanced breast cancer, which is fixed and ulcer. So the core biopsy show, luckily, invasive breast cancer with estrogen receptor positive. So we give it to her aromatase inhibitor in terms of letrozole 2.5 milligram. This is the 6 months following. It's almost healed. The half family is very happy. This is a fourth case scenario. This patient has a tumor, solid mass lesion, about 30 millimeter. And here you may not be able to see, that's a microcalcification, B5A. The radiologist measured about 55 to 60 millimeter. This is the ML view, this is a CC view. So she has a larger breast. She won a conservative breast surgery. So this is a plan to do it next week. That's all from me. Is there any questions?
ဟုတ်ကဲ့ဆရာမေကွန်းနေရှိပါတယ်ဆရာတော်တော်များများတော့ဟိုချက်ပေါက်ဆရာမအမားဖြေထားပြီလို့လေဖြည့်ပြရမှာလည်းကျေးဇူးအများကြီးတင်ပါတယ်လို့ဆရာဟိုကလေပထမဆုံးမေကွန်းကလေ whole versus partial breast adjuvant therapy ကိုသိချင်ပါတယ်ဆရာ
ဟုတ်ကဲ့ဒီ radiotherapy ကိုပြောတာမသိ
breast adjuvant therapy ဆရာ whole versus partial လို့တော့မေးထားဆရာ
အဲ့ဒါ radiotherapy မှာပါ
ဟုတ်ကဲ့ဆရာ
ဒီ radiotherapy မှာသူတို့ကဘယ်လိုလုပ်တယ်လဲဆိုတော့whole breast radiotherapy ဆိုတာ tangentially ပေးတာပေါ့နော် partial breast radiotherapy. Partial breast radiotherapy is aiming mainly at the tumor bed. It depends on size of the tumor and the type of the tumor. Usually we give radiotherapy the whole breast tangentially. In detail no?
Okay, sir. Question throughပြန်ထည့်ပေးလိုက်ပါမယ်
Okay, okay. ကျွန်တော်ဒီပြင်ပြန်ဖြေပေးမယ်ဒီမှာကျွန်တော် research လုပ်လိုက်ပြန်ထည့်ပေးလိုက်
ဟုတ်ဆရာ so our next question ကလေ ultrasound breast နဲ့ mammography difference လေးသိချင်ပါတယ်ဆရာ
ခင်ဗျာ ultrasound နဲ့ mammography ultrasound difference ultrasound ကတော့ဒီကျွန်တော်ခုနပြောထားသလိုပဲလေဘယ်လိုပြောရမလဲဒီ So ultrasound the reason we are doing ultrasound is targeted imaging. So if there is a mass lesion or the specific point pain, so we cannot do ultrasound in the whole breast pain. So if there is a specific pain area, yes, we can go and do that imaging ultrasound. And then we can do a guided biopsy from the specific area. So that's the two, the point we can do that. In mammogram, just only the vision. Mammogram, we can only see things, either microcalcification, mass lesion, specular lesion, or distortion. So ultrasound, we can see that either anorganic or solid mass, irregular mass, malignant. So you can see that that's the ill-defined mass. So it is more, this is the hyperechoic lesion. This is the hypoechoic lesion. Malignant mass, this is a cyst. I don't know whether they understand my answer or not.
Okay, next question why breast cancer occur in younger
Younger, why? Individual mutation genetic mutation the under 35 all the under 35 patients we send for genetic assessment hoping that we may find some familiar trait such as BRCA 1 or 2, TP53, but over 80% of the time we can't find anything. So we have to assume that this is the individual genetic mutation to that specific patient.
Okay, next question why chemo prevention is only for 5 years?
After the 5 years, what they have a lot of the research in about 20-30 years ago about the chemo prevention. So they have mainly 2 projects with one arm is for tamoxifen, another one arm is for letrozole. Beyond 5 years, they have no longer differences between the cancer occurrence, and they bring more side effects and complications. So that's the reason it's being only licensed for only 5 years, especially for the tamoxifen. They bring more side effects, and even for that aromatase enzyme, they only can give for the postmenopausal patients. So they bring more complications of the fracture, bone complications. That's the reason.
Okay, next question when does we perform screening breast lump and neoplasia.
These breast screening program it is a very expensive program. In UK, it is free. So we have to target the risk group. We cannot screen the whole population from 25 to 72. This is the one point. Second point, so we have to target the population risk group, which is the higher risk. There are two peaks. One is 50 to 55, the highest peak, followed by after 65. So once women have been invited for the breast screening, they have a mammogram, and they have a huge amount of anxiety, whether they will be called back or not. Even once they are called back, the anxiety is tremendous. So again, you know, there will be like false positive and repeated biopsy. So we have to outweigh these things against the mortality. So that is the reason we have targeted for the risk group mammogram. That's called a breast screening program. In United States, they call United States and European countries, they usually call back every 2 years, but because they are not free in United States and Europe country, they have to pay a lot of health insurance. But England is more free. Everything is free.
ဟုတ်ကဲ့ပါဆရာဆရာကမေးခွန်းနေရာမရှိတော့ဆရာ
ဟုတ်ကဲ့ကျေးဇူးပါ
ဆရာခုနကျန်တဲ့မေးခွန်းလေးတစ်ခုကိုဆရာအဖြေပေးပြီးတဲ့ခါကျရင်ကျမတို့ဒီ Google Drive ထဲမှာသူတို့တင်ပေးလိုက်ပါမယ်ဆရာ
ဟုတ်ကဲ့ပါ
ဟုတ်ဆရာ
အားလုံးကျေးဇူးတင်ပါတယ် Stay safe Thank you
ဟုတ်ပါဆရာလက်ချပေးပြရတဲ့လည်းကျေးဇူးအများကြီးတင်ပါတယ်ဆရာ
ဟုတ်ကဲ့
ဟုတ်နောက်ထောင်ပေးတဲ့မောင်လေးညီမလေးအကောင်လုံးလည်းကျေးဇူးတင်ပါတယ်ခဏနေကြရင် pediatric session မှာပြန်တွေ့ကြမယ်နော်